Today we're going to be talking about one of the most tragic and yet fascinating disorders, schizophrenia. It's tragic because of when it typically hits the person, right when they are about to reach the height of their independence, leave home. And it's fascinating because so little is understood about what might be contributing to the symptoms as well as the potential causes. We'll discuss some of the potential risk factors for schizophrenia, but it should be known that scientists don't fully understand what contributes or causes schizophrenia, and we're still trying to uncover some of the neurobiological, so what's happening in the brain to cause the symptoms that we observe with schizophrenia. But before we begin, here is your dad joke of the day. Watch what you say around egg whites. They can't take a yolk. Get it? All right. Let's talk about schizophrenia on to more serious things. So the word schizophrenia was coined by Eugene Bleuler, a German psychiatrist, which was trying to get at this idea that people with schizophrenia seem to have a disconnection between emotion and cognitive function. So the word schizophrenia literally means split mind, and oftentimes what occurs with people with schizophrenia is that they express inappropriate emotions, or they may fail to show emotions appropriate to the circumstances. But schizophrenia was first described by a German psychiatrist, Emil Kraepelin, which you may have heard about in the other lecture on psychopathology. But despite the fact that it was first described in the late 1800s, we are still attempting to understand how this disorder works or what goes wrong with it. Diagnosis, as is the case with most mental illness, requires prolonged deterioration of daily activities. Individuals, typically when they are diagnosed with schizophrenia, family members have noticed a change. Something's wrong. They no longer engage in the daily activities where they are interacting with their peers or going to work or taking care of themselves. In fact, they end up kind of secluded in their rooms for fear of leaving their home. So family members are typically the ones to notice the red flag and call attention to a medical provider regarding the change in the person's behavior. Schizophrenia typically is a combination of a variety of symptoms, including hallucinations, delusions, disorganized speech and thought, which we'll talk about in the coming slides. It's also considered a movement disorder because some situations or conditions of schizophrenia involve catatonia, which is a complete absence of movement. And as I mentioned before, it also may involve loss of emotional responses or appropriate social behaviors. The problem with schizophrenia is that there's such variety in the symptom presentation that oftentimes two people with schizophrenia may not present with the same combination of symptoms. And so this may make diagnosis really challenging because two people with the same disease may not have the same combination of symptoms. And this is why some psychiatrists or psychologists believe that schizophrenia may not, may not be a disorder by itself, but may be kind of a combination of disorders that we're mistaking for schizophrenia. I mentioned this already. It is a tragic disorder because of when it strikes the individual. It robs them of the opportunity for independence, and it takes away some of the most advanced functions that make us uniquely human. Our ability to think, reason, believe what we are seeing and hearing. And so it makes you question what reality is. We're going to look at the symptoms of schizophrenia through the two-compartment model. This allows us to view the symptoms of schizophrenia in more simplified terms. The first compartment or bucket of symptoms represents or are called positive symptoms. They represent the presence of abnormal behaviors that should not be there in a person but are, and they involve hallucinations, delusions, disordered thinking, as well as disordered movement. Negative symptoms represent the other bucket or compartment, and they are the absence of normal behaviors. So behaviors that should be there but aren't present in a person with schizophrenia. And so symptoms in this bucket include lack of emotional expression, lack of motivation, as well as social interactions. So let's talk about some positive symptoms a little bit more. So most medications that are used to treat schizophrenia treat this category or compartment of symptoms, but they don't really treat negative symptoms. Hallucinations, which are one of the categories of symptoms under the positive compartment, these represent perceptions that don't represent or correspond to any external stimulus. So because perceptions involve sensory systems, hallucinations can occur in any sensory system. What we know now, given an accidental discovery of this, was that hallucinations represent spontaneous activity in a sensory system. So typically we see, think, feel with our brain. And so when there's random activity in areas of the brain that typically handle sensory perception, we are going to experience those perceptions, whether or not a stimulus exists on the outside. And so hallucinations represent the random activity in our brain that correspond to no external stimulus, that weren't triggered by any external stimulus or the activation of your sense organ. Delusions represent beliefs that somebody holds to be true, despite the fact that there's evidence against that particular belief. So there are three types of delusions: delusions of persecution, delusion of grandeur, and delusion of reference. Delusion of persecution represents a belief that somebody is out to get you, that somebody's trying to hurt you in some way, and they might be beliefs that somebody's trying to kill you. Delusions of grandeur represents a belief that you are a really important person in some organizational system, and that system may be the government, or you might be somebody who's kind of reincarnated as a person from the past, like Cleopatra or Napoleon. Delusions of reference represent a belief that there are hidden messages for you in things that may be completely innocuous to somebody else. So for example, if you see a billboard, you are going to read messages in that billboard that were designed specifically for you and nobody else. Typically that is not the case, but it is a delusion of reference, a belief that there are hidden messages in random things, random objects, designed specifically for you to get and nobody else. Disordered speech and thought are the last kind of bucket of symptoms within the positive compartment. Typically, people with disordered speech, with schizophrenia, they have problems thinking clearly, and as a result, their language and their communication is disordered as well. They often have illogical or incoherent thinking. They might have distracted thinking. They might interrupt people and not be able to hold a conversation in kind of a linear way. And they might have tangential speech, random thoughts that occur to them that they might express in a conversation. With regard to prevalence, schizophrenia is pretty rare. It affects anywhere from 1 to 4 people per 1,000. Most frequently, the average onset of diagnosis or average onset of the disorder is in young adults, roughly around their early 20s, late teens. But you will also likely to see them in teenagers, young people, as well as older adults. Men seem to be more commonly affected with schizophrenia, and their symptoms tend to be worse than women. And for reasons still unknown, it seems to be more common in people raised in cities versus rural towns. The prognosis, which is a word for kind of the outcome or trajectory of the disease or of any disease, prognosis for schizophrenia is way better than it was decades ago. About a quarter of individuals remain permanently impaired, but most don't get worse. Recovery can occur in some individuals after a brief episode, but the problem is many others fluctuate between not experiencing symptoms and experiencing symptoms. So there are a variety of likely causes for schizophrenia. It is unclear if there is one factor or cause that's worse than others, so I'm going to share several with you in this lecture. The first idea is that, and we'll talk about this later on as well, is that schizophrenia is believed, at least within the research community, to be a neurodevelopmental disorder. What that means is that something goes wrong during brain development that ultimately contributes to the onset of schizophrenia later in life. So either the genetics or the environment in utero during pregnancy kind of sets up for an abnormal brain development, and then that brain that is not completely developed normally is kind of triggered by stress later in life and precipitates likely the first episode of schizophrenia. So some evidence to support the fact that genetics contributes to schizophrenia. Monozygotic twins, these are identical twins that share 100% of their genes, have a much higher likelihood of both developing schizophrenia than dizygotic or fraternal twins. Relatives of individuals with schizophrenia also have a greater risk of developing schizophrenia themselves, and relatives of people with schizophrenia have some cognitive impairments, although not full-blown schizophrenia, have cognitive impairments that are reminiscent of those seen in schizophrenia. Just to illustrate kind of the relationship or the genetic contribution of schizophrenia, what I've outlined here are two higher risk situations that make schizophrenia more likely. If you are a child of parents, both parents that have schizophrenia, you have a 46% of developing schizophrenia yourself. If you are an identical twin whose twin has developed schizophrenia, you are likely to have developed schizophrenia at 48%. So this is your risk. So as you become more closely related to somebody with schizophrenia, your risk of developing schizophrenia increases. As I mentioned earlier, schizophrenia is considered a neurodevelopmental disorder, and so researchers have developed a neurodevelopmental hypothesis to try to explain the potential causes or contributing factors to schizophrenia. It is thought that schizophrenia originates due to some sort of abnormal nervous system development, and the causes for that abnormality could be genetics, could be trauma during early or prenatal environment, and some evidence to support that earlier prenatal environment contributes to schizophrenia. What you're seeing here is a list of circumstances where schizophrenia is more prevalent in these cases than others. So if the mother had a difficult pregnancy, labor, or delivery, if the mother was undernourished during pregnancy, if the mother had an infection during early to mid-pregnancy, if the mother had a stressful pregnancy, if the mother's Rh factor, which is what contributes to blood type, positive or negative, if the mother's Rh factor is different from that of the baby's, so if the mother's negative and the baby is positive, the baby's likely to have schizophrenia later in life. If after birth the child is exposed to lead or toxins during early life, they're more likely to develop schizophrenia. And finally, patients who were infected by Toxoplasma gondii, which is a virus that is found in cat feces, if they're likely to be infected by it, it's going to affect brain damage and then make it more likely that the person develops schizophrenia. So hopefully you can see that these cases all represent circumstances where the potential for brain damage may have occurred, making it more likely that a person develops schizophrenia. So what kinds of brain abnormalities do we see in people with schizophrenia? So there's several. First, you see a reduction in the volume or the size of the frontal and temporal lobes. So you're not seeing uniform brain loss. We're seeing decrease in brain mass in the frontal and temporal lobes. Additionally, we see enlarged ventricles. So you have spaces in your brain filled with fluid called cerebrospinal fluid. And normally these spaces are a certain size, but when you have tissue loss somewhere in the brain, these spaces get larger. So whenever we see enlarged ventricles, they represent brain loss somewhere else in the brain. So one criticism of using enlarged ventricles as an indicator of, cause for schizophrenia, somebody might argue that, well, maybe the person had enlarged ventricles over time, that having schizophrenia over their life and experiencing repeated episodes of schizophrenia may have caused tissue loss. Well, that's not necessarily true, because even in patients that have experienced schizophrenia for their first episode, very first time, they have enlarged ventricles, suggesting that whatever loss occurred prior to the first episode of schizophrenia. So up here, you're looking at a PET scan of somebody with schizophrenia and somebody without. And what you're looking at is this kind of butterfly-shaped structure here. These are the lateral ventricles. And again, you don't need to be trained to notice that this structure is much larger in somebody with schizophrenia than somebody without. Even more pronounced, these ventricles are in 28-year-old male identical twins. The one on the right has schizophrenia, the one on the left does not, and you see the arrows pointing to the lateral ventricles, which are much larger in the patient with schizophrenia compared to the one without. So again, this is one indicator of something having gone wrong in the brain during development, causing a shrinkage of tissue somewhere else, resulting in larger spaces. In addition to kind of tissue loss in the frontal and temporal lobe and enlarged ventricles, there are fewer and smaller neurons in the prefrontal cortex. That's what PFC stands for. And specifically, there's an area of the prefrontal cortex called the dorsolateral prefrontal cortex, where these neurons are especially small and fewer in number. The dorsolateral prefrontal cortex handles a function called working memory. You may recall this from the lecture on memory. Working memory is a type of memory that is short-term. It allows you to hold information in real time and manipulate it and use it whenever it's necessary. Evidence of tissue loss has been seen in adolescents. So these are adolescents with schizophrenia versus unaffected adolescents. And anywhere you see red represents tissue loss. So again, the tissue loss is not uniform, affecting the dorsolateral prefrontal cortex as well as the temporal lobes and a little bit of the occipital lobe. So we're not seeing uniform loss here, but there's definitely loss of tissue associated with schizophrenia. The other unique characteristic that kind of puts the rubber stamp on this idea that something went wrong during development is the fact that in patients with schizophrenia, their hippocampal neurons are disorganized. So if you recall, the hippocampus is a structure that handles learning and memory. This can only occur during development. So to illustrate to you what we're looking at when we mean disorganized, here on the left is a patient with schizophrenia, and this is kind of a slice through their hippocampus. Here is an unaffected hippocampus, and it may be difficult for you to see, but each of these neuron cell bodies have kind of like a point, and these points are headed in the kind of the left direction. They're oriented all in the same direction. But if we look at that point or those points in neurons of somebody with schizophrenia, you'll notice they're kind of all going which way. And so if we illustrate in a cartoon what these neurons may look like, here's what they're supposed to look like. Very organized, structured, all facing the same direction, allowing for easy communication with these cells. But in patients with schizophrenia, because their neurons are disorganized, kind of oriented in every which way, you can imagine that communication with these neurons then becomes really, really challenging. I want to mention that this type of organization occurs during prenatal development. It does not occur later in life. It cannot change later in life. So this piece of evidence solely supports the idea that something went wrong during brain development that may likely contribute to the onset of schizophrenia. With regard to treatment, schizophrenia has to be treated. It's not one of those mental illnesses where it will be fine without treatment. Symptoms can get much worse if they are not treated, and the person may end up causing themselves or others harm. Antipsychotic drugs, which are the class of drugs used to treat schizophrenia, were first discovered in the 1950s, and these antipsychotic drugs, or typical antipsychotic drugs, tend to only relieve the positive symptoms of schizophrenia. Chlorpromazine, or the brand name Thorazine, was the first antipsychotic drugs. What they noticed with these particular drugs when patients with schizophrenia took them, they got much better. But when they stopped treatment, the symptoms returned, illustrating the fact that schizophrenia cannot go untreated because the symptoms will remain or get worse. Just to illustrate the improvement seen with schizophrenia or schizophrenia symptoms with antipsychotic drugs versus placebo over the course of 30 months, patients who were on antipsychotic drugs experienced greater improvement after 30 months compared to patients who are on placebo. So medical treatment or medication is necessary to treat schizophrenia. So how do these typical or traditional antipsychotics work? Most typical antipsychotics work by blocking the actions of the neurotransmitter dopamine at the synapse. Specifically, they are blocking the receptor or specific type of receptor for dopamine. We know that they're working through dopamine because when people who don't have schizophrenia take large doses of amphetamines and cocaine, they can produce hallucinations and delusions. If you don't recall, amphetamines and cocaine increase dopamine release and activity at the synapse. And so scientists, because of how antipsychotics work and the fact that amphetamines and cocaine can reproduce positive symptoms of schizophrenia, came up with the dopamine hypothesis of schizophrenia. They're arguing, or this hypothesis argues, that schizophrenia is caused by too much dopamine in certain areas of the brain. Because when we block dopamine action with antipsychotics, we end up relieving symptoms of dopamine. The other thing that kind of supports the dopamine hypothesis, or it's an add-on to the dopamine hypothesis, is that dopamine release is controlled by another neurotransmitter called glutamate. Glutamate is the major excitatory neurotransmitter in the brain, and scientists have discovered that there's too little glutamate being released in the prefrontal cortex. Similarly, or additionally, when we administer angel dust or PCP, which blocks a specific glutamate receptor, it can produce both positive and negative symptoms in unaffected individuals. Now, while antipsychotics are great at relieving symptoms, they don't come without any consequences, or they have major consequences. So antipsychotics are a dirty, dirty drug. While they're super helpful for schizophrenia, they come with major risks. So some of the side effects of antipsychotics are motor related. So in addition to kind of contributing to the positive symptoms, dopamine is also used in the voluntary motor system. So most of the side effects of antipsychotics tend to be some sort of motor dysfunction. One of the side effects is known as Parkinsonism. So it's called Parkinsonism because the symptoms look like Parkinson's disease, but they are caused entirely by typical antipsychotics. The Parkinsonism is a side effect that is not permanent. So if a person stops taking antipsychotics, this side effect will go away. Tardive dyskinesia, on the other hand, represents involuntary movements of the lips and mouth. And unfortunately, tardive dyskinesia is a high risk for somebody who's been on antipsychotics for a long time and is a permanent side effect. So even if you stop taking antipsychotics, tardive dyskinesia lasts. Because of this great risk of antipsychotics or typical antipsychotics, scientists developed atypical antipsychotics, and examples of some atypical antipsychotics are risperidone or clozapine. These atypical antipsychotics are great because they don't produce or they reduce the risk of tardive dyskinesia, so the motor dysfunction is less common with atypical antipsychotics, and they also relieve both positive and negative symptoms, whereas the typical antipsychotics only relieve positive symptoms. However, you can have some other dangerous side effects that can occur with atypical antipsychotics. Something called, although rare, something called neuroleptic malignant syndrome is a situation or a side effect of atypical antipsychotics. You can have high fever, muscle rigidity, as well as confusion. You can also develop something called agranulocytosis, which is a dangerously low white blood cell count. And then finally, more common side effects, which are unpleasant, include high cholesterol, type 2 diabetes, as well as metabolic syndrome. So even though atypical antipsychotics are better in some ways compared to typical antipsychotics, they too have problematic side effects. So it's no surprise that people who are on antipsychotics typically don't want to remain on them because they take the antipsychotics, they feel better, and they feel like they don't need the medication because the side effects are so awful. So that's where psychotherapy comes in. Psychotherapy is not effective on its own to treat schizophrenia because schizophrenia has to be medicated to produce any changes in symptoms. So psychotherapy is largely used to increase compliance with medication to ensure that the patient remains on their medication and doesn't go off of it. So psychotherapy in combination with medication produces the most effective treatment for relief of symptoms of this disease. All right, that's it for this lecture. Here is the summary for the lecture. I'm not going to go through it, but here are your exit ticket questions for this particular lecture.